Hello everyone, welcome back to our NCLEX RN Review. And for those who just joined us, we are on the third day of the 90-day free NCLEX Review classes in this YouTube channel. And we'll be doing this daily at 12 p.m. Eastern Standard Time. And so we'll be covering all nursing subjects and rationalization of 2000 NCLEX style questions. And today I'll talk about the nursing care and management for a patient with kidney transplant, and we'll have some Q&A about the AKI and chronic kidney disease. So to get started here, we'll talk about the first topic, actually, the only topic for today, which is the kidney transplant and also the care and nursing management. And so this is a procedure that involves surgical implantation of a healthy kidney from either a living or a deceased donor into an individual whose kidneys have stopped functioning correctly. So basically we're talking about a person that has end-stage renal disease. So if the patient does not have living donor, they might be added to a waiting list for a kidney, maybe from a deceased donor. And so the wait time for the deceased donor kidney can vary based on how well you're going to match with the donor. And so the length of time that the patient has been on dialysis and the wait list and also the predicted survival after the transplant will be considered. And so some of those fortunate individuals can find a match in a few months, while others may have to wait several years. So that's the reality in the present time. Now, for the kidney transplant, there are some preliminary steps, preparations in order for this procedure can be started. And so the recipient's tissues actually will need to be compatible with the donors, and the kidney donors can be alive or could be non-heart beating or could be a deceased donor. And so there will be some compatibility testing. It could be the evaluation of the blood type between the donor and the recipient, and also histocompatibility, wherein it will cover human leukocyte antigen and also minor antigens. And so this is going to determine the successful likelihood of the transplantation without any rejection. And so it's going to really match the specific antigens, particularly the HLA, and this is to minimize the immune response and to ensure that the transplanted tissue or organ is accepted by the recipient's body. Now, for those who are receiving a kidney from a living or, let's say, a related donor with compatible tissues, they are the most with the highest likelihood of a transplant success. Now, if the kidney's from a deceased or, let's say, a heart-beating donor, they must be adequately perfused to ensure that the organ is viable during the procedure. And the donated kidney is going to be surgically placed in the recipient. Now, at this point, we're going to have to talk about the requirements on the kidney transplantation. And so the recipient must qualify according to the criteria here. And so this is just, this is not the list really about what's going to disqualify them, but these are some of the requirements that could qualify them into getting a donor. Now, one of those is the advanced renal failure that may be requiring them to have a dialysis. It could be peritoneal, it could be hemodialysis, or as a case with, let's say, having a end-stage renal disease, okay? Or maybe a projected lifespan of at least 5 years. So they can qualify if they have that criterion. And also complete comprehension of post-surgery instructions and care, because they need to be proactive by themselves on actually how to take care of their own new kidney as well. And to get started here, there are also many risks here that you see. There's a whole lot of lists that will also gonna pose a risk to possibly maybe this would really disqualify them, because these are certain conditions that can increase their risk of maybe rejecting the kidney. And so they have to deal with a whole lot of things, especially the surgical procedure itself is already stressful. And it is expected that they're going to have to go through a lifelong immunosuppression. They have to take lots of those immunosuppressive medications, and those medications can be toxic to the body as well. And so they need to be tested with the drug levels. And so this is going to be a bit more stressful after they get the kidney. And also the stress or the risk of having the organ rejection as well. Now, as you see here, age below 2 years. Well, we're probably going to disregard that right now since we're talking med-surg, but I'll just include that because for those infants that may need organ transplantation, they are known to have fragile immune systems, and this would really make them very difficult to handle the complexities of the surgery and also the necessary immunosuppression that they need to take at the young age. Now, it's really going to make them very vulnerable to developing so many complications. Now, for those patients that are above 70 years old, they are known to developing so many advanced heart disease or maybe some malignancies. And this is really going to increase their risk for developing the complications with the kidney transplant. And also, they're going to have other health issues, could be cancer or a pre-existing comorbidity that would really put an extra risk to the surgery and will slow down their recovery. And so they also need to manage the immunosuppressant medications, which they really need to adhere, because if they're going to miss taking those immunosuppressant medications maybe more than a day or so, they can really encounter some major problems. Now, another thing is the advanced and treatable cardiac disease. That's another issue, because if someone has a major cardiac problem, the stress of the surgery itself and the effects of the immunosuppressants can be too much for their heart to handle. And this is going to end up with a whole lot of complications as well. Now, also with substance dependency, or let's say, yes, substance dependency could be, it could pertain to the chemical dependency as well. And so for those people with this kind of substance abuse, they might struggle with sticking to their medication schedule, and I'm referring to the immunosuppressants, and possibly not able to adhere to the follow-up care that they're supposed to go. And this is something that would be really crucial in order for them to avoid any kind of organ rejection and to manage their immunosuppression effectively. Now, there's also chronic infections or, let's say, systemic diseases like HIV, hepatitis B or C. These conditions are actually going to weaken the person's immune system. And so balancing the need to prevent the organ rejection with the risk of infections become really challenging for these people, because they already have a pre-existing immune suppression in the immune system, plus the suppression of the immune system that will be caused by the medication. Then this will really cause a whole lot of major issues for them. Now, another thing is the blood clotting disorders, or maybe there is such thing as coagulopathies, or let's say problems in the immune system. And so if they have that kind of issue, they're at higher risk of bleeding during the surgical procedure. And with those certain immune disorders, this can also complicate the management with the use of the immunosuppressant drug. Now here we go, we have severe or morbid obesity. So this is going to bring the patient into higher surgical risk, possibly maybe related to infections because of poor wound healing as well. And this is going to be much more challenging, especially when they're going to be taking the immunosuppressant medications. Now, another here highlighted is diabetes mellitus, and this can make the wound healing slower. And I'm not talking just about the superficial incision that is involved. Actually, it's the wound healing, the graft inside with the newly implanted kidney, and it has to be attached to those blood vessels from the body. And if there is such slow wound healing, then it can be at risk to developing some kind of infections and other complications. And it would be very difficult for them to control their blood sugars, especially that drugs could be involved, like corticosteroids, because corticosteroids would be one of those immunosuppressant medications that will be prescribed to them. Now, another thing would be the chronic lung disease, because these problems can also lead them to develop breathing issues during and also after the surgery, and this will make their recovery much harder, and this will increase their risk of developing more complications. Now, another thing is the untreated gastrointestinal diseases. So I'm referring here to the peptic ulcer disease, or a PUD. So if a person has an untreated GI problem, it can also cause problem, because the oral medications that they will be taking, and these are the immunosuppressive medications, there will be poor absorption of those immunosuppressants. And also, this will cause an increasing risk of GI complications after the surgery. So I hope that you're able to recall maybe at least half of these risks. And what you can do to help out in remembering these information is actually think about those complex medical issues that are very common. Let's say cardiac disease, diabetes, high blood pressure. And for those people that are using substances like maybe alcohol or any of those illicit drugs, those are the major issues that will probably disqualify them, or it could lead to so much more complications if they will be able to get that donor organ. Now, we're going to talk this time about the nursing care directly right now. And so we will be requiring you, I want you to think as a seasoned nurse, especially when you are taking the NCLEX. All right? So that's our deal. I want to make sure that you're going to do your best to use your clinical judgment in actually applying all these information that you have gained in order that you can synthesize all those problem-solving skills that you have learned all throughout your study in nursing. And so there are so many nursing interventions that are highly required for a kidney transplant patient before the procedure is done. And so we're going to focus on several key areas, and this is very exciting but also complex. And make sure that you also put yourselves in the nurse's shoes, that you're actually going to play a very critical role in preparing the patient for the surgery. And so at this time, we're going to deal first with the nursing actions before we actually send the patient for the surgery. And so during this time, the recipient, the patient who's needing the new kidney, they're going to be receiving a blood transfusion, and the blood is coming from the living donor. And so this is something that can really help in several ways in order to improve the matching between the donor and the recipient. And it will also help in reducing the risk of rejection, and also will enhance the survival of the transplanted kidney. Now, another preparation here is to have the hemodialysis within 1 day after the kidney transplant. So I'm saying that it's part of the preparation because they need to know that this is something that has to be done right after. So they need to be compliant that, hey, I thought that I would not be doing any more dialysis once I have the kidney. No, that's not true. The dialysis actually will be done even after the kidney transplant, because there are some changes in the body. Probably the kidneys are still kind of trying to adjust with a new environment, and also the other processes that has taken place. And so there is a need to do the dialysis for a few sessions right after the transplantation. And so this is also a common practice shortly after a kidney transplant, because this will also remove excess waste products and also excess fluids until the new kidney will start to function completely. Because you're not really going to expect the new kidney to work 100%. No, it has to deal with the new environment, new host, actually. And so, yeah, this is the reality, and make sure that you are including that in your patient education so your patient will comply with the dialysis after the transplantation. Now, at this time, we're really going to focus into the real nursing action. So at this point, we're going to be responsible in arranging the schedule of the pre-op lab test, and I've listed here so many. And one of those is the blood chem, and this is going to assess the kidney function, the current kidney function of the patient, and also their electrolyte levels, and also other metabolic processes or parameters, so we can identify and also correct any of those imbalances that they have. All right? So if there are some major imbalances in their electrolytes, or maybe a drop in the calcium, that needs to be corrected before they can experience any complications during the surgery. They have to be at least close to the normal range. Now, for the complete blood count, or the CBC, that should include the differential count. And this is intended to check for the anemia, also to see if there is such kind of an infection, maybe an elevated white blood cell count, or leukocytosis, or if there is pre-existing anemia, maybe a very severe form of anemia, maybe 6.5, that needs to be addressed before the surgical procedure. Okay. Now, another is coagulation studies. This is very important, guys, because the kidney transplant is a major bloody procedure. This is the organs are actually supplied with so many blood vessels, and this patient can possibly bleed out if they probably have some coagulopathies, wherein there is probably a deficiency in their clotting factor, or maybe their platelet count is probably dropping. So we need to keep an eye into these studies to make sure that they're going to bleed out during the surgical procedure. Now, another is urine culture. Why we need to take a look into the urine culture. We have to detect if there is an existing urinary tract infection. That needs to be treated before the transplant, because this can also reduce the risk of post-op infection. Again, focus on the urine culture. Don't just focus on one. So you have to think about all these lab studies that I listed here. Now, another is blood typing and cross-matching. Well, this is to help us out in confirming the compatibility between the donor and also the recipient, in order to reduce the risk of organ rejection. All right, so I hope that this is going to give you a little bit more of an idea of what the role is. So we're not just going to arrange the schedule and making sure that they're going to show up to their appointment at the lab center, but you really need to pay attention into the lab results as well once you retrieve those lab information, and make sure that you're going to relay it to the medical provider as well, and also to the healthcare team involved in the care of the patient, so everyone will be alerted, and at least they would be able to point out some major problems before things can go out of hand. All right. Now, at this point, we also need to administer some pre-op medications. And I'm not talking about sedatives or anxiolytics. No, I'm talking about pre-op medications that will be needed in order to prevent any infection and also to prevent rejection. And so these are the two classifications that I'll be talking about. These are your prophylactic anti-infectives or antibiotics. So the reason for that is to prevent infections due to the immunosuppressive therapy that the patient will receive. So There are always disadvantages to any kind of medication because the immunosuppressant will help prevent major immune response by the patient that can possibly cause rejection, but they need to take the immunosuppressant in order that they will not be rejecting that donor tissue. But in order for us to protect the patient from a possible opportunistic infection to occur, then we need to prevent that from happening by administering them the prophylactic anti-infectives. Okay? And so we want to make sure that the patient is going to receive the correct, appropriate dose so that we can monitor for any kind of adverse reaction as well. All right? So I really want you to think ahead and use your clinical judgment. It's not that because the doctor has ordered it that it will be okay. No, you have to use your brain because some of these medications are going to be weight-based and also according to the laboratory studies. So if this medication is probably like a standard dose, this might not be applicable to this patient that will be receiving a kidney transplant. It could be toxic for their system. And so you want to make sure that you're really going to do your diligent study. Make sure that you are going to also question what the doctor has ordered because they can make mistakes as well. And it has happened several times. We nurses are actually covering their butts. And so the next classification here are the immunosuppressant medications. So listed here are your corticosteroids, cyclosporin, azathioprine. We also have the mTOR or the mammalian target, rapamycin, mTOR inhibitors, and the everolimus. So it doesn't mean that we're going to have to give all of these medications. We are just listing here the different possible immunosuppressants that can be prescribed to the patient. But most often, these medications will be given in combination to really have that much more effective therapeutic effect into the patient. Now we'll go into the corticosteroids. So what is this classification? Well, we know that corticosteroids are your synthetic or could be your external source of the glucocorticoids because our body really produced the corticosteroids, right? Or the glucocorticoids. And so at this point, the body will, or the patient will be needing an outside source in order to really reduce the inflammation and the immune response that the patient might be developing. And so we are going to educate the patient about the potential side effects of the corticosteroids. So I'm throwing a question right now. So what do you think are the commonly known adverse effects of glucocorticoids? I'm giving you a second right now. All right, giving you the answer. So one of those adverse or side effects is weight gain because the corticosteroids can actually cause sodium and water retention. It can also cause mood swings. So you really have to properly assess your patient before, during, and after glucocorticoid therapy because this can alter their mood. Some of these patients might go into psychotic behavior or mood changes. That would be too extreme. And another side effect here is the increase of the blood sugar level. It can cause hyperglycemia. So for those patients that are already diabetic and they have to go through with this process of pre-medication or pre-op medication, you really have to think ahead. What can I do for this patient in order to prevent more complications, especially that they're already diabetic? And so think ahead. Maybe the dose of this patient's insulin will be increased according to the physician's order. So this is something that you need to think ahead. Because the medication, the pre-existing dose of insulin that they might have at the current time might not be able to control the hyperglycemia when they're taking the corticosteroids. All right? So that's how I want you to think. Think ahead diligently and also be careful in your judgment. You want to make sure that you're reading back into the literature because sometimes you can make mistakes as well. Now, we're going to have to talk about the cyclosporin and also the azathioprine. So these are also immunosuppressants that can be used as a pre-op medications, but we're going to have to monitor regarding the blood levels and also the labs of the patient, like the renal function, even though they already have the end stage. But we also need to monitor onto the other lab values, okay? Now, this can also affect the liver function. So that's why I want you to go over the different lab studies, because it can alter the liver function, and it can also cause some problems in the blood cell count or the complete blood count. All right? So think ahead. Now, another is the mammalian target of rapamycin, or the mTOR inhibitor. So what are these medications in this category? So we have the example of that. So this is a group of medications that can prevent, well, actually it will interrupt the T cell signaling, helping prevent the rejection. And so this is going to suppress the effect of your T cell, which is one of the forms of your white blood cell, to fight off the donor kidney. So it will suppress the immune system, especially the white blood cell, the T cells, from attacking the possible donor tissue. And so what we're going to do here is to monitor the patient for possible side effects, let's say dry mouth or ulcers in the mouth. Their wound healing will be delayed, and also some metabolic changes. So I hope that you're writing down all those other informations that I did not show in or not include in the PowerPoint, because those are the things that actually are possibly going to be asked in the NCLEX. Now, the other one is the monoclonal antibodies. So what are these medications? We have the examples, the daclizumab and also the basiliximab. These medications will target the T cells to prevent the activation. And so our role here as nurses, we are going to educate the patient about the necessity of adhering to really comply and taking the medication all throughout the regimen. And we're going to have to monitor for any infusion reactions, because this is going to be given through an infusion. And we also have to monitor them for any appearance or any manifestations of infections. All right, so I hope that you're able to digest those kind of heavy information there. You really need to have that. You need to get used to have some heavy information so you will be able to handle the exam. Now at this point, we're going to have to look into the next role that we're going to have. We're going to have to educate the patient before the kidney transplant. And so we are going to explain to them possible questions or possible items that they did not understand. And so our role here is to be a support as an advocate in order that the patient will be able to participate in the entire regimen, and so they will be compliant with the treatment as well. Now, how are we going to promote the patient education at this point? They're already overwhelmed with the surgery, thinking about the possible complications that they might have. They're already stressed out. That's why we really have to step in here. Patient education can really calm the nerves. That's right. And so one of those things is to help explain to them the process of the transplant procedure. So we are going to walk them through the whole process from the pre-op to the post-op, so they will know what to expect. So it's just not about verbal conversation at this point. So part of the education here is actually providing them some printouts, let's say pamphlets that are going to be available in the institution, because most of the institutions in the US are actually mandated to make sure that we are providing them education before we're gonna give them some treatments or any kind of procedures or any medications. We are mandated to educate them, okay? That's part of the care. It's just not about verbal teaching, no, that's only part of it. And so we have to make sure that they have a that kind of information that is easily understood in their own language, because we can provide them with different languages, translations of the pamphlets, and something that can be easily understood, not something that would require knowledge as an RN. No, that would not help them. And so we need to walk them through the information, make sure that they are reassured that they are open to, can ask questions if they still do not understand those information that they have. Now, another thing is to explain to them or present to them the risks and the benefits. Okay, I'm not talking about the initial conversation that should take place between them and the medical provider or the surgeon, because they are the primary professionals that should be going through with the patient about the risk and the benefits. But we can support the medical provider in actually, we are gonna, what do you call this? Support, we're gonna have to at least smoothen out those possible unclear sections. And so what we can do here is to explain to them the risk and the benefits. We want to make sure that the patients are fully informed, and we have to break down the pros and the cons of the transplantation versus the dialysis, so that they can really make the best decisions for themselves, because this is something that could really affect their lifetime. This is a long-term commitment. Now, at this point, we have to participate in counseling the patient and also support services. So even so, if we're not really gonna be the main person to provide the formal counseling, what we can do here is we can offer, and probably we can refer them or connect the patient to the counselor or any support groups that can help them out, so they can listen to them actively with empathy and make sure that they can also provide encouragement to these patients. Now, another thing is peer support. So this is very important in this journey, because we need to explore some more ways to connect to our patients and with others who have been through it. And so they really need to have this kind of sense of belonging, connection with the same patients, so that they can share the experiences and how they were able to get through the difficult time. And another thing is we're going to have to teach them stress management techniques. And this is something that will help manage their stress. And so part of it will be to go over some deep breathing exercises, guided imagery, and also relaxation techniques that will help them to stay calm and centered. Now, we need to also set realistic expectations with a patient, and to make sure that we have to keep it real with our patients. Do not give them false reassurance. We want to make sure that we are clear of what's possible and what is not. So we will discuss to them the transplant process honestly, and talk to them about the possible challenges that they might face along the way. And this is going to be helping them to have that realistic expectation as well, and we can help them with a much more prepared decision. And also, they probably would not be blaming us in the future. How could they do that to me? They didn't tell me anything about this. And so we want to make sure that we can support them just as much as possible. Now, another thing is we can encourage our patient to ask questions and also have that open communication, so that we can also chat about maybe if they had any uncomfortable questions, so they would be opening up to you, and also share their concerns. So as nurses, it's part of our job to create a safe space for them to do just like that. Okay? So I don't want to go too deeper here, because that's not going to be my role, but this is the reality. I've been a nurse for over 24 years, and there are so many things that were not taught in nursing school. There are so many things that I've learned way much more in the clinical area, and this is one of those things, being empathetic to your patient. Now, what are we going to do here next is we're going to have to deal with the patient during or after the surgical procedure. So at this point, we're going to have to go deeper into the nursing care plan for a patient after the surgical procedure. So again, I want you to think critically as a seasoned nurse when taking care of this patient with the new kidneys. And so the immediate post-operative area, this is the busiest part of your care to this patient. So if you are in the recovery room, or let's say the ICU, or let's say the medical surgical unit, think about just getting ready to take care of this busy patient to start your shift. And it can happen probably in the middle or maybe towards the end of your shift. So you gotta be prepared. Now, during the immediate post-op, our nursing care right after the surgery is to make sure we are monitoring the vital signs every 15 minutes initially, then every 4 hours. So this is not really going to be applicable on all different nursing levels. If it's the recovery room, they're probably going to be doing this a whole lot more in ICU. This is something that we can probably do in maybe a step-down unit or telemetry or med-surg, right? Especially if you are just meeting this patient. But most often is the frequency of the vital signs checking, and also checking for the other, observations. It would require much more frequency here. And so what we're going to include is going to check also the intake and output. So most of these patients, or all of these patients, will be coming back to the unit, or let's say the PACU or the recovery room or the ICU. Most of these patients will going to end up possibly with a urinary catheter. I'm talking about that indwelling catheter. And so we're going to be required to do an hourly I's and O's measurement. I'm talking about diligently measuring all the output that you had emptied from the urinary bag, or let's say measuring the JP drain or whatever hemovac that's collecting the drainage because the patient has a wound, and also checking into the IV intake. You gotta be diligent in measuring this, because if you're gonna fail in measuring accurately, this will really cause problem to your patient. It will return to you. You're gonna get busier if you're gonna fail doing this. And so we are going to monitor the urinary output of the patient. So it is expected at this point that at least we have to have that goal that they need to urinate at least 30 mLs an hour, nothing below that. Because if it is less than 30, that is very significant. It simply means that maybe there is a problem in the surgical site. Maybe there is thrombosis. There could be an obstruction. Or it could be there's an ongoing rejection of the new kidney. Yes, it can happen as early as within an hour. And so when this happens, if our intake and output states that, hey, my patient is not really putting out 30 mLs an hour, this is something that you really need to notify to the physician or the surgical team or the doctor. All right? So you have to also check on the urinary appearance. Make sure that you have at least a documentation of what the color of the urine is right after you receive the patient. Is it bright red? Is it pinkish? Is it kind of just blood tinged? Or maybe it was light pink when you received the patient, but let's say 30 minutes later on it went to a bright red. Well, that's something that should be addressed right away. There is an active bleeding going on. So any kind of urinary color change that you can see in this patient, make sure that you report immediately to the physician or the medical provider, surgical team, so that this patient will be sent back into the OR. Okay? Now, we're going to have to also check for the organ rejection as early as right after they are sent out to the PACU. They need to be checked for a possible organ rejection. And so the organ rejection can be, it can possibly occur right there and then. It could be a hyperacute type of organ rejection that can occur within the 48 hours after they receive the new kidney. That is just bad, right? or it could be acute, which can happen within months, or actually 1 to 2 years, okay? Or actually, that would be the chronic, and months to 2 years rather is the acute, and the chronic is 1 to 2 years. So I accidentally reversed that one, so forgive me. So the acute is actually the kind of rejection that can happen, let's say months after the surgical procedure, up to maybe a year, whereas the chronic would be something that can occur during the 1 to 2 years after the procedure. Now, why is this acute, hyperacute rejection occurring? Well, this is something that could be possibly be brought about by the antibody-mediated response that could possibly cause formation of the blood clots into the transplanted kidney, and this will occlude the vessels, and this will cause massive cellular destruction. And I'm referring to the kidney, the new kidney. And so this is a process that is not reversible, I should say. So again, I will say this is irreversible. So when this happens, it has to be dealt with accordingly. Now, what to expect as a recovery room nurse or the ICU nurse taking care of this patient? Well, one of those signs would be fever. That is the earliest sign that there is rejection, and part of that would be hypertension. Then there's also pain at the transplant site or the graft, and there is also elevation of the blood urea nitrogen and also the creatinine. Can you imagine that? You're expecting really, you're happy that your patient is now getting a new kidney, and all of a sudden everything went back, it reversed. Your patient now has an elevated BUN and creatinine. How disappointing is that? And so this is one thing that you need to anticipate. Just don't expect way too much. Expect the worst so you won't get disappointed. That's how I do it. And so I always prepare for the worst to happen in my patient. Even though I do my diligent care, I always think about the worst possible complication to happen. So I'm ready to fight whenever I get to encounter those complications. Now, we also have elevation of the white blood cell. Well, because that's part of the inflammatory process, right? There will be leukocytosis. It doesn't really mean that there is now an infection. The white blood cell count can also get elevated when there is an inflammatory process going on. And of course, that is part of the rejection process. And there's also edema, okay? And why? Why is there edema? Well, of course, the new kidney is not working. And so what's going to happen? There is poor filtration. So again, let's go back into the original picture of a patient having a chronic kidney disease, or let's say, chronic kidney disease, wherein they have fluid volume overload. And so the same kind of classic manifestations that they had during the CKD is pretty much the same manifestations that you will be seeing in this patient with a rejection. Maybe not all of the manifestations will be completely similar, but some of these manifestations will be at least 75% similar. Okay? Now, what is going to be done here when there is immediate or hyperacute rejection? Well, this is going to require immediate removal of the donor kidney. Yeah, disappointing, right? You as a patient probably have dealt way so much, you have to pay for all the expenses, and now this kidney is not working for you. How bad is that? Very disappointing. And so, it will be removed right away, or else the body will do some more havoc into the other systems. Now we're going to have to talk, of course, as soon as you're going to encounter these assessment findings, you're going to have to notify the doctor ASAP. I'm talking within 15 to 30 minutes. As soon as you assess this patient with all these rejection signs, notify them right away. Do not wait more than an hour. Do not wait for the next shift. That's going to be a neglect of care. Okay? I'm just telling you right now. Whenever there is a critical manifestation or a critical lab result that will come back to you, we are mandated to notify the physician within 30 minutes. And in the hospital that I work with in the past, usually we are to notify the medical provider within 30 minutes. For some laboratory findings that are abnormal, critical labs, I should say just critical labs, we are supposed to call the medical provider within 15 minutes upon receipt of the news, upon we have read the abnormal or critical laboratory in the computer system. As soon as we get that news, or as soon as we read that laboratory result, we document that in the nurse's notes, the time exactly we receive the information, and then we have to document as well the time when you notify the physician, because the quality assurance department will be tracking in how you are dealing with this serious situation. You have to be timely in delivering your care and also your notification. I'm getting serious, right? Yeah, because I'm one of those nurses that actually do chart checks. Now, another thing that we're going to have to do here is to actually administer the immunosuppressive meds. So this is something that will be more applicable to the acute and the chronic kind of rejection. This administration of immunosuppressive meds, like right after the surgical procedure, this is something that would be more applicable to the acute and chronic. And I'm telling you that because with the hyperacute, remember that the kidney that was donated will be removed, right? So it will not stay in the recipient's body. And so right after the surgical procedure, and so if the patient has acute or chronic rejection to the new tissue, they're going to proceed with taking the immunosuppressant medications aside from taking the preliminary or the pre-op. So they're going to continue taking the corticosteroids, the cyclosporin, and also the monoclonal antibodies. And this one right here, the removal of the donor kidney, this is indicated for the patient that had the hyperacute. I just don't have any way to put it there. So yeah, and just to make sure, clarifying things right now. And so another thing that you're going to have to do at this point, post-op, is to monitor the patient for infection. And this is a common cause of first transplant, year morbidity, and also mortality. Again, infection is a big deal. And so what we're going to do here as the PACU nurse or the ICU nurse or even med-surg nurse, we're going to have to detect for any early signs of infection. So what are those early signs of infection? This will come back probably several times in any NCLEX question. The reason for that is to measure your judgment if you're able to capture those possible risks that could really cause more complications. The NCLEX will test you how well you're going to be able to capture even the subtle manifestations. Because if you're not able to capture, then you're not worthy to become an RN. That's the honest response right there. You really need to be able to detect those potential side effects or complications, abnormal findings, so that we can notify the physician, we can intervene about it, and we can prevent complications. And so again, back to the infection here. What are we going to expect? Or what are those signs of infections that we are going to look for? Well, of course, dyspnea, that's one. There's also fever, right? And also abnormal discharge from the surgical site. There is now there is increasing drainage coming from the surgical site. The dressing is getting much more like soaked, it's watery, or it can be purulent. Maybe there is now an ongoing odor, or the patient has a trend in their temperature. There is now an elevation of the temperature. Guys, I've seen so many nurses just telling me, that's okay, that's still within normal limits. I know, it's still within normal limits, but when you're going to look into the trend, make sure that you're really following into how is this trend going. Is it going down? Is it going up? If it's going up, then that's not good, even though it's normal, because it simply means that something is going on. Let's say when you were on shift yesterday and the patient's temperature was 97.8 degrees Fahrenheit, and the night shift documented maybe 98.2 degrees Fahrenheit, and the morning shift documented maybe a temperature of 98.9. and the midship nurse documented maybe 99.1. Yeah, all those lab or all those temperature readings are normal, right? But look into the trend. Are they going up? Are these readings going up? This is not a good sign. This is something that should give you a red flag in order for you to prevent a much more destructive complication. Now, at this point, we really need to keep an eye out for these signs immediately, okay? Some of these manifestations can also accompany redness into the surgical site. Some of these would be fatigue, general discomfort. Those are the accompanying early signs of an infection, okay? Now, I want you to really stress the importance of being a critical thinker here, because as we know, the patient is already taking immunosuppressant medication. So that means they will not be able to fight for any infection. And another thing is that their immune system will probably impair our defenses. Let's say some of these patients probably will not develop any fever, right? So it's kind of masked because of the immunosuppressant. So you don't assume that the patient doesn't have an infection because they don't have a fever. That's just not the clue that we are looking for. There are so many things. And so with that immunosuppressant, it does really make things much more complicated in capturing the infection. All right. So other than that, maybe white blood cell count being elevated, a left shift. And so at this point as nurses, what we're going to need to do here is to notify the provider ASAP. Once we encounter these assessment findings, we have to make sure to educate the patient, the family, the spouse, in order that they're going to be able to also report for any possible signs of infection. They're going to be your helper. And I actually like to educate my patients' family members, because they're actually going to be able to help you as well, to tell you if something is going on with their family member. And so many times I encourage them to do that in order that I'll be alerted. Although it sometimes can be so annoying because they can overdo it, but you have to deal with it. I mean, they're part of the care as well. Part of that would be to encourage them to do frequent hand hygiene. That's very important, all right? Avoiding crowds. And this is just like a general patient education, not just about applying this into the acute care setting, but also when the patient gets discharged, right? And they need to watch themselves for any signs of infection. And so they need to avoid crowded areas, avoid sick people, especially for those with active infections. What else? Those people that might have had a recent chickenpox or vaccinations with live virus. Yep, that's part of our precautions here. We need to tell them that. And also make sure that they wear face masks if they're going to be out in the public. If it's unavoidable, they have to be out there. But as much as possible, they have to avoid big crowds to prevent any opportunistic infection to occur. Now, part of the care to fight off infection is to administer anti-infective medications, antibiotics, okay? And yeah, antibiotics. And we have to monitor the patient as well. Let's say, for example, they really develop the infection. And so there will be follow-up appointments as well. Make sure that there's some resolution. If they have some kind of respiratory infection, then they need to have a follow-up visit to the medical provider's office to see if they're positive still in their blood cultures, or maybe their sputum exam. Then there's going to be ongoing care to this patient. Now, another complication or a possible risk that can occur in a patient with a kidney transplant would be the hemorrhage. This is very common as well. The kidney is a highly vascular organ, and during the procedure there is a break in the continuity of the tissues, and so hemorrhage is something that you should anticipate. So what are we doing here? We are going to check the surgical dressing for any signs of bleeding, all right? Not just the dressing, you have to carefully look into the amount of drainage. For example, if the patient has an accompanying wound vacuum, let's say like those JP drain or hemovac, then you have to use your judgment. Is this drainage way too much for this acute phase post-op? Is this 200 mLs an hour? Or is this just maybe 10 cc's per hour? So maybe that's acceptable, but maybe your patient has an ongoing massive bleed, then you really need to notify the doctor if the bleeding is way too much. And if, as much as possible, if there's probably no other way of telling, no measurement or no device to measure, what you can do is to estimate the blood loss. Maybe use maybe weigh the dressing. That would be helpful as well, to estimate the amount of blood that has occurred during the bleeding episode. And at this point, we really need to also encourage transitioning the oral fluid intake, or let's say from IV to oral fluid intake, in order to help them hydrate. And also, this is something that we need to be careful. Make sure that you're offering oral fluids as ordered, and make sure that the bowel function has returned. There's already peristalsis. Okay, so if the patient is tolerating some sips of clear liquids, then go ahead. Now, if the provider the patient has significant blood loss, I'm telling you, significant blood loss, then you really need to notify the provider right away. It's a critical finding. Again, notify the doctor as early as possible, 15, 30 minutes. Okay, maybe 30 minutes is even like late already. 15 minutes would be much more ideal. Now, administer IV fluids. This is something that would help restore the circulating fluid volume to counteract the effect of the hypovolemia. And another problem really with the hemorrhage, when there is a fluid loss or volume loss, it can compromise the circulation, not just into the body system, but also it will compromise the blood supply into the new kidney. So imagine that you have a brand new toy. Not really, should I say toy? Or if you have a brand new organ inside your body, you want to make sure that you're taking care of it, right? That this organ should be getting enough blood supply, that it should get at least 20 to 25% of the total cardiac output, right? That's what I said during the introduction of my lectures. So if there is now a hypovolemia, decreased circulating fluid volume, then expect that this kidney will also be dysfunctional if the bleeding is prolonged. Now, we really need to administer the fluid boluses. Maybe there's a need for us to administer packed red blood cells if there is a significant blood loss, a significant drop of the red blood cells or the hemoglobin count. We want to make sure that we are going to do that. And we have to do our prompt assessment as well, intervention to prevent more complication at this point. Now, urinary elimination, what is this? This is going to be something that we need to really keep an eye on, because maintaining a urinary output is what we are looking at. Because if there is a decreased urinary output, then simply there is something wrong with the new kidney. Probably there is rejection, or it could be a thrombosis, and a possible removal of the kidney. We don't want that. Now, part of the care in post-op phase, because the patient would really need an ongoing INO measurement, strict intake and output measurement. So most of these patients will come back to you or will be admitted to the PACU or the recovery room. They mostly will have a urinary catheter. And the reason for that is to help us to measure the output accurately, and also to allow checking of the urinary output. If there is, let's say, what do you call this? An assessment, let's say there is presence of clots in the urinary output. This is already concerning, because if there is clotting in the drainage tube, then something is possibly going to happen in the next hour. It can possibly obstruct the outflow, all right? And so we have to anticipate administering the continuous bladder irrigation, which is actually going to require a three-way catheter, okay? Not the two-way, because if you are going to use, or yeah, if you're only going to expect two-way catheter, then it's only going to compose of the inlet for the balloon, in order that you can inflate the balloon, and the other one is for the the drainage bag, right? And so this is not going to allow you to do the irrigation. So most of these patients will be sent to the PACU with a three-way catheter. So most of these patients will come back already with the CBI, the continuous bladder irrigation. That's something that we'll be discussing as well in the next topic, in the prostatectomy in the bladder, or the benign prostatic hypertrophy. And so with that, part of the care is to make sure we are going to irrigate the bladder in order to prevent any occlusion, and also there will be optimal urine flow. And once the flow of urine is somewhat more stable, there's no more active bleeders, the removal of the catheter will be done as early as possible. And the reason for that is to prevent complications. In the US, it's very strict as far as insertion of or maintenance of the urinary catheter. As soon as the patient is going to be able to ambulate post-op, if there is a pre-existing urinary catheter, if there's no need for that, then it has to be removed, because urinary catheters can cause urinary tract infections, I should say ascending urinary tract infection. Now, another issue that we need to deal with is oliguria. Okay, so what is this? This is a possible complication because possibly there is an obstruction. So again, this is going to be detected through proper intake and output measurement. We need to notify the medical provider right away. And so as much as possible, we notify them as early on, because there are so many things that we can do for them, such as the administration of the diuretics and also possible dialysis, okay? And why are we giving diuretics at this point? Diuretics, let's say the mannitol, thiazides, the furosemide, and again, there's so many more information, right? So I hope that you're writing notes. So for the mannitol, this is a osmotic diuretic that will actually help preserve the urine flow, and it will reduce the risk of acute kidney injury. So the mannitol here is applicable in this scenario. It's not needed for a cerebral edema. Again, this is intended for the oliguria status post kidney transplant. So the filtered mannitol will actually draw the water into the nephrons of the kidney, and it will promote diuresis. That's why we are going to expect this medication to be ordered. And some doctors might be a little bit more cautious. That's why thiazides and furosemide will also be ordered, but not all of these, right? Okay, don't expect to give all these different classes, because we don't want to cause way too much fluid loss. We only want to initiate diuresis. We don't want to overdo it. So for the thiazide and the furosemide, they are considered like less effective in promoting the filtration rate. That's why they are the secondary and the tertiary modality here. Okay. Now, also the dialysis is going to be ordered by the medical provider after the kidney transplant in order to facilitate the filtration, because the kidney at this point probably is not doing its 100% yet. And so this will help remove the body waste and also to lessen the burden into the new kidney. We want to help, we want to assist the new kidney in filtering those waste products, and also to remove those extra fluid from the body until the new kidney will be able to function 100%. Okay? So I hope that you're able to capture all those explanations that I have given. Now, at this point, we're going to have to also keep an eye on excessive diuresis. So extremes are not good, right? So at this point, if there is excessive urination, polyuria, I'm talking about 4 liters, 5 liters in 24-hour period. That is way too much fluid out from the system. And so this can happen after a successful kidney transplant. And so we want to make sure that we are expecting we are going to expect really that the kidney will work better, right? But the excessive diuresis can also occur. And the reason why this happens, it's because the sudden restoration. Let's say, for example, the body is now, hey, we got a new friend here. We got a newbie that is really a hard worker, brand new. And so the body will be adjusting to the new organ, right? And so probably at this point, the kidney will be overwhelmed, and also the interplay of the body hormones, the antidiuretic hormone, the aldosterone, surprised by the new friend. And so with all these changes occurring at the same time, this can lead to the excessive diuresis. And however, though, the diuresis can be a problem. It can really cause hypovolemia. Again, this will require us to call the medical provider ASAP. All right? Because when there is uncontrolled hypovolemia and low blood pressure, it will also decrease the blood flow to the graft. The same mechanism when there is hemorrhage. And so that's why we are going to call the doctor right away. And so we have to promptly address it by possibly administering fluid boluses of normal saline in order to counteract the hypotensive effects. Now, constipation, yes, that's also part of it. This is something that can occur possibly because of the bowel manipulation during the surgical procedure, and also possibly the effect of the anesthesia. Okay, it can slow down the peristalsis, and possibly from the analgesics that we are providing or that we are giving to the patient post-op, right? Because our patient would need pain medication. You don't want our patient to be in pain, in agony. You really have to control their pain. And so the drawback is the constipation. And so what we're going to do is to monitor for the bowel sounds and to also monitor the bowel movements closely. And part of the care is to administer stool softeners, could be laxatives, increasing their fiber in the diet, and also to, I would probably not say increase fluids yet, because we're still in the process of restoring the fluid volume at this point. We don't want to overwhelm the system, but we want to start with at least softening their stools. Now, also, fluid electrolyte imbalances can occur during the post-op phase, and we are going to monitor the intake and output as well, and also the electrolytes. This is very critical. We got to measure the daily weight as well, because the daily weight will really give us the information if the patient is gaining weight. Maybe the patient now is edematous from the accumulated fluid because the new kidney is not working well. And so we want to make sure that we are doing our diligent documentation in order for us to notify the medical provider, make sure that our assessment will also guide our treatment plan. Now, again, we're going to have to notify the medical provider ASAP for any electrolyte and fluid imbalances so we can correct them right away. So at this point, you probably would be needing to replace IV electrolytes as well if there is such an imbalance. And so at that point, when you are looking into the laboratory, and usually this is going to be a daily, there will be daily renal function tests looking into the creatinine, the BUN, the complete blood count, the electrolytes, sodium, potassium, mag, also phosphorus, chloride. And so we have to really pay attention if there's any rapid or abrupt changes from the previous assessment. Okay, always do that. Assessment is actually going to help you in passing the test. If you have a good assessment skill, you have a higher chance in passing the NCLEX, because The NCLEX is actually asking the most basic questions. Yep, that's true. Most basic questions. Now, at this point, we're going to have to promote again that Stancoast is offering the 90 days of free NCLEX training classes. So we are doing this daily. So please don't misconstrue that. We are actually doing this daily. So I really want you to tell your friends who are trying to pass the NCLEX, make sure that they are going to grab this perk, and also make sure that they are going to attend to the classes. They can also review into the recorded videos that will be posted in the, actually it will be posted right away as soon as the live session is done. And again, we're going to cover the nursing subjects, and also we're going to do some rationalization of about 2,000 NCLEX style questions. And so we want to make sure that you're going to subscribe and also like this video. And on top of that, we're going to also promote the course that we are offering in the website www.stancoastnclasscoaching.com. We have there so many perks as well. So there will be 10 hours of animated videos. There's also lots of on-demand video, the recorded lectures, 2,000 plus practice questions, and there's also audiobook, ebook, and mock testings. And this is accessible 24/7 for 6 months with your subscription, of course. And this will also include the 200 plus NGN questions, and this will be self-paced, and you also have about 70% discount for this month only. So I really want you to grab this opportunity. And if you have any more questions, you can ask in the conversation thread in this video, and also look into the description below, so you will be able to click on those links to go into our website, to check our website directly. So that's it. We're going to continue our lecture here, and again, now we're going to continue with the Q&A. So here we have our scenario. The question is about a 58-year-old man was recently diagnosed with end-stage renal disease secondary to chronic kidney failure. He has initiated hemodialysis. Oops, sorry. Click that one. He has initiated hemodialysis treatment to manage his condition. And given the risk of disequilibrium syndrome in patients new to hemodialysis, the nurse diligently monitors the patient during the dialysis session for any signs of symptoms suggestive of this disequilibrium syndrome. Again, the question states, a 58-year-old man was recently diagnosed with end-stage renal disease secondary to chronic kidney failure. He has initiated hemodialysis treatment to manage his condition. Given the risk of disequilibrium syndrome in patients new to dialysis, the nurse diligently monitors the patient during the dialysis session for any signs of symptoms suggestive of this disequilibrium syndrome. So what are these symptoms? Is it A, restlessness, irritability, and weakness? In B, we have elevated blood pressure, rapid heart rate, and fever. We also have headache. For C, confusion, muscle twitching. And D, we have low blood pressure, slow heart rate, and decreased body temperature. Okay, I want you to pick your choices right now. Choice. So what is your answer? I'm giving you at least a few seconds. All right, so time is up. We're going to have to go through each item here, or each option. Okay. Now, at this point, we have letter A, restlessness, irritability, and weakness. Now, this group of symptoms may occur in our patient having a dialysis, right? But they are not specific to the disequilibrium syndrome. And they can be indicative of other conditions or maybe other complications. that could be not related to the rapid solute removal and brain swelling. So we are going to eliminate that. What we are looking for here are those manifestations that is closely associated with the disequilibrium syndrome. Now, B, what is this? Elevated blood pressure, rapid heart rate, and fever. What do you think about that? Again, these manifestations can also happen in a patient with a disequilibrium syndrome, but again, they are not specific to the disequilibrium syndrome. The elevated blood pressure, actually, the rapid heart rate, and also the fever, they can be manifested by other issues, maybe fluid volume overload or maybe electrolyte imbalances. And so with the fever, it is associated with so many other disorders, maybe associated directly with infection. And so we are going to eliminate that because it doesn't really suggest about the disequilibrium syndrome. Now we'll talk about the C here, headache, confusion, and muscle twitching. Well, sounds like fancy, right? So this is a possible answer. We're going to have to recall here that during the dialysis, especially the hemodialysis, for those patients that are newly diagnosed, they just started the hemodialysis session, and so they are at a higher risk to developing the disequilibrium syndrome. Okay, please take note of that. They are at a higher risk to develop this because their body is not used to the change in the osmolality with the dialysis treatment. Okay, they are used. Their body is already used to elevation of the blood urea and nitrogen most of the time, and so if there is now a filtration, removal of the blood urea nitrogen at a certain rate, their brain will respond to it like very differently. It can cause some changes in the central nervous system, and it can cause headache. It can cause confusion. It will lead to muscle twitching. Okay, and the other neurological symptoms that is also associated with the disequilibrium syndrome is what do you call this? The osmotic changes in the brain cells. So when the BUN, the high level of blood urea nitrogen, is removed from the body in the vascular compartment, it will cause osmotic changes into the brain cells due to the shifting of the fluid, and it will cause brain cell swelling. All right, so there will be an increase also in the intracranial pressure. Potentially our patient will go into seizure, okay, aside from having increased intracranial pressure. So add that to your notes, increasing ICP and also possible seizures. Now, our goal here as nurses is to make sure that we are assessing the patient for this specific neuro manifestations, especially during the dialysis session, not just the brand new dialysis patient, so that we can recognize early on the management also to treat the problem. So it's not limited only to new dialysis patient, but it can also happen even the chronic dialysis patients. If the dialysis nurse is rapidly removing the urea, or let's say the rate of removal is way too fast, the patient can go into this problem, disequilibrium syndrome. So we have that as our potential answer, okay? Now for letter D, what is this? Low blood pressure, slow heart rate, and decreased body temperature. What is this? So similar to the other options, these symptoms are not really characteristics of the disequilibrium syndrome. And so the low blood pressure itself, the slow heart rate, the bradycardia, they potentially can happen during the dialysis. And also same thing with the low temperature, okay? But they are not, again, specific to the disequilibrium syndrome. They can also be found in other disorders. Now,
again, we're going to have to go through. So our answer here is letter C. Okay. Now at this point, we're going to have to point out the different test-taking strategies that you need to apply. So again, what we're going to do here is to identify the key concept. What is being asked in the scenario? Okay. Is it asking for the manifestations, the signs and symptoms? And specific to that is that we are being asked about the disequilibrium syndrome. Okay. So narrow your, let's say, narrow your decision making at this point as far as like with the assessment findings. You have to kind of pick this common manifestations associated with this problem. And so we are also going to have to eliminate those obvious incorrect options. So what are those obvious incorrect options? These are those answers, those non-specific symptoms. Okay, I'm talking about symptoms that are not directly pertaining to the disequilibrium syndromes. That's why I started eliminating that one. Same thing with letter B and also with letter D. So always answer by elimination. Do not look for the correct answer. Because if you're only looking for the correct answer, you're going to easily miss it. So answer by elimination. Look for those options that are not related to the problem that we are looking at. We have to look for those options that can potentially delay the treatment or could potentially harm the patient. And so this is how you're supposed to answer when you are answering for, let's say, SATA, or select all the apply, or a multiple choice, or even with the matrix multiple choice, the same thing applies. You have to answer by elimination. Now, another tip here is to recall the disequilibrium syndrome and what it primarily affects. So the system that will be involved here is the central nervous system because of the rapid solute removal during the dialysis. So restlessness, irritability, and weakness, yeah, this can be associated with some other electrolyte imbalances. Low blood pressure, it doesn't really correlate with CNS problem. Elevated blood pressure, no. So you have to narrow down your options here. Twitching is one. There is actually irritability in the meninges at this point. The patient is going to go possibly into a seizure episode. Confusion, that is because the patient has an increasing ICP that is causing edema, the edema causing ICP, I should say, and the headache caused by the influx of the solvent or the water into the brain cells. That's why they're going to have that headache. Now let's move on into the next question here. We have the situation, it's a female client is admitted for treatment of chronic renal failure or, which is a condition characterized by the gradual loss of kidney function over time. So as a nurse, you know that this disorder increases the risk of, is it A, metabolic alkalosis as a consequence of hydrogen ion retention? Is it B, increased serum calcium levels due to kidney failure? Or is it C, retention of water and sodium due to a significant decrease in the glomerular filtration rate? Or is it D, decreased serum phosphate levels stemming from kidney failure? I'm going to give you a few seconds here to select your option. All right, I hope that you were able to pick your answer. So let's go through the choices here. Let's have letter A first. Okay, what is being asked really? A female client is admitted for a treatment of chronic renal failure, a condition characterized by the gradual loss of kidney function over time. As a nurse, you know that this disorder increases the risk for. So what we're actually looking at right now is the complication that a chronic renal failure can possibly have. Okay? We're looking for the complication. That is what this question is wanting us to do. So is it A, metabolic alkalosis as a consequence of hydrogen ion retention? Is it true that when your hydrogen ions are retained in the bloodstream that it will cause alkalosis? Hydrogen ions. Well, let's go through. The kidneys actually is going to play a big role in the normally functioning body. It will be responsible to excrete the acids, the hydrogen ions produced by the body's metabolism. However, in the chronic kidney disease or the CRF, the kidneys have already lost their ability to adequately excrete the acids. So what is going on? It will cause accumulation of those hydrogen ions. Now, another thing that we are going to talk about is that the ammonia production in the kidneys, supposedly in the normally functioning body, it will be able to help buffer the acids, because the ammonia is going to be converted into an ammonium, and this will be excreted in the urine. Okay? Now, in the chronic kidney disease, it will reduce its ability in excreting the ammonia. That is why there is that metabolic acidosis, not alkalosis. Now, also in CKD, there is a bicarbonate loss because the kidney has already lost its function in producing bicarbonate, and so it will not be able to buffer the effects of the metabolic acidosis. So we are crossing this one out because this is what makes it wrong. It should be acidosis. Now let's take a look into letter B, increased serum calcium levels due to kidney failure. Now, I've talked about this during our introduction, that the kidneys are supposed to what? Synthesize, activate the form of vitamin D into calcitriol, right? From calcidiol to calcitriol. And recall now your concept about the involvement of vitamin D in the absorption of calcium, right? And it will actually lead to hypocalcemia if there is a deficiency in vitamin D. So we are going to cross this out because it's saying increase. There is no increase in the calcium level in chronic renal failure. It will decrease. Okay? Now, another reason that the patient will have hypocalcemia is that the in CKD itself, there is also a secondary hyperparathyroidism wherein the parathyroid gland will become overactive due to the low active vitamin D and calcium levels, and this will cause the parathyroid gland to secrete the hormone to stimulate the release of the calcium ions from the bones. Now, this is really not going to be sufficient to maintain the normal calcium levels, and so that is why the patient will end up with hypocalcemia. So we are going to remove that one, XX, and letter C. Let's find out. Retention of water and sodium due to significant decrease in the glomerular filtration rate. Well, at this point, there is a possible potential, or there is really a retention of water and also the sodium in the body because of a significant decrease in the glomerular filtration rate. Okay? Now, the patient at this point is really at risk for fluid imbalance. They're going to usually come into the hospital with the difficulty of breathing, cardiac dysrhythmias. These are the main complaints why they are seeking help, because of the shortness of breath. But we'll know more when we look into their labs. It's just not about the shortness of breathing. It's going to be electrolyte imbalances that can affect their cardiac function and also the brain function. So at this point, the patient will actually have have some problem to concentrate in the urine, and that's why there's also fluid retention at this point. Okay, now this is a possible correct answer. So now let's check letter D. Decreased serum phosphate levels stemming from kidney failure. Before we go into letter D, let me just look here real quick. Retention of water and sodium due to a significant decrease in the glomerular filtration. Yes, okay. And so this is actually pertaining to hypernatremia, right? Okay. Guys, I want to emphasize right now that in chronic renal failure, it's either hyponatremia and hypernatremia. What I emphasized during my lecture was hyponatremia, okay? I've researched this very deeply, and the reason why I chose hyponatremia, because most of the population with a chronic renal failure that is admitted during the acute phase will manifest hyponatremia more than hypernatremia. I said either of the two can happen, but most of the population admitted with chronic renal failure will usually manifest hyponatremia. And the reason for that is, again, the inability of the kidneys to concentrate. So they will have that kind of like delusional type of hyponatremia. All right? Delusional type. That's why there is either hyper or hypo in CRF. Now, let's move on to letter D, decreased serum phosphatase levels. Well, let's check the facts. Well, in chronic renal failure, or CKD, there is actually going to be a high phosphate levels, because we know that calcium and phosphorus are inversely proportional. They are actually the exact opposite. So if there is hypocalcemia, what you're going to expect here is the phosphorus levels will elevate, and this is going to become a toxic to the system. And this is associated as well with the dysfunctional mechanism of the parathyroid gland, because the body is sensing that there is significant hypocalcemia. So the release of the parathyroid hormone is an attempt to also equalize the amount of calcium. However, at this point, the filtration rate is already disturbed. So the calcium is actually not going to be at the normal level. It will be readily, it's not going to be stabilized. The body will not be able to compensate that low calcium. And so the hyponatremia cannot be mitigated by the increased resorption of calcium from the bone structures. What can happen though is that the phosphorus instead will be elevated at this point, okay? Now, what would be our testing strategy here in order for you to properly, correctly answer this question? Well, we're going to have to read through the question and make sure that we are reading through the case. Is it about identifying the risk associated with the chronic renal failure? Yes, we are being asked about the potential complication here. So that is your key. And another is we're going to have to eliminate those incorrect options. So look for those options that are clearly incorrect based on what you had learned, your stocked knowledge, and also the information that you were able to collect from the scenario. So for example, we have letter A and D. This can be easily eliminated because in chronic renal failure, typically the patient will end up with metabolic acidosis, not alkalosis, okay? And then you're also going to eliminate letter D. It's because it said decreased. Well, in CRF, it's always increased phosphorus. So you have to get rid of those two immediately. Now, another is you're going to have to recall the pathophysiology in the chronic renal failure and also the changes that will take place. And once you recall those changes, the pathological changes, I should say, We want to make sure that we are aligning with the manifestations that are presented in the options. So in this scenario, the chronic renal failure will lead to the decreased glomerular filtration, and that is why the person will end up with retention of water. It will cause the delusional type of hyponatremia. Okay? That is why we're going to select letter C as our correct answer. Letter D is wrong. Now let's move on to the next. Okay, I'm going to do one more question before we're going to end. Okay, we have a question here. Mr. Smith, a 55-year-old female, Miss Smith, a 55-year-old female presents with complications related to uremia, necessitating renal replacement therapy. Due to the difficulties encountered with the hemodialysis, peritoneal dialysis has been initiated as the chosen mode of treatment. Which of the options below signals a significant problem during Ms. Smith's peritoneal dialysis procedure? Okay, let me read that question one more time. Ms. Smith, a 55-year-old female, presents with complications related to uremia, necessitating renal replacement therapy. Due to the difficulties encountered with hemodialysis, peritoneal dialysis has been initiated as the chosen mode of treatment. Which of the following findings signals a significant problem during Ms. Smith's peritoneal dialysis procedure? We got options: A, hematocrit of 34%, B, white blood cell count of 22,000 cubic millimeter, and we have letter C, potassium level of 3.5 milliequivalents per liter, and D, blood glucose level of 210 milligrams per deciliter. So, what is being asked here is that which of these findings could contraindicate the peritoneal dialysis? What could pose a problem into continuing the peritoneal dialysis? That's what this question is implying. I'm giving you a few seconds to answer. All right, time's up. Now let's go back into the question again. Our patient has been using the peritoneal dialysis because she had some issues with the hemodialysis, right? Or some difficulties. And now we are tasked to identify those findings in the options that could contraindicate, that could become a problem while the patient is going to go through peritoneal dialysis. So let's go to letter A, hematocrit level of 34%. Now I want you to recall the normal level of the hematocrit count, especially in the females. So this is something that you really need to remember, okay? So at this point, we have to talk about the normal range for the female hematocrit count. So for females, adults, the usual range will usually fall between 36 to 46%. And for the males, it will be 38 to 50%. Again, for females, that is, let me put my pen in here, 36 to 46%. And there might be some slight variances with what laboratory has been used for the testing. For the males, it will be around 38 to 50. Okay. And again, it can vary. It might be there might be some slight differences, but this would be our reference for now. And so, looking into the range here, our patient has a low hematocrit, but does it contraindicate the use of the peritoneal dialysis? Probably not. We understand that it is low, right? The hematocrit will give us an idea how the red blood cells is compared to the amount of the plasma. So this will tell how diluted the blood is or how concentrated the blood is with regards to the red blood cells to the plasma. So at this point, the reading is lower, 34, so it looks like our red blood cell count is lower compared than the normal range, and so there is more solvent in the system compared to the red blood cells. Now, it's still kind of like considered as an acceptable range. It's not normal, but this will not contraindicate the use of the peritoneal dialysis, because considering that our patient would need some regular blood sampling, so there will be blood draws, so that could also, their counts would be decreased, right, if there is regular blood draw. And so this is an expected finding, but however, it's not going to contraindicate the use of PD. This is an expected finding. The patient has chronic renal failure. They don't have much erythropoietin to produce or to stimulate the kidney, to stimulate the red bone marrow to produce the red blood cell. That is why our patient has anemia. Now let's take a look in letter B. White blood cell count of 22,000 per cubic millimeter. Well, what do you think? What is the normal white blood cell count range in adults? Well, simply recall that would be around 5 to 10,000 per cubic millimeter. Okay, that would be my usual range. In some cases, some scenario would accept up to 11,000. So anything above 11,000 would be very significant. But I usually would narrow down my limits here, like 5 to 10, just to get them have a little bit more or less room for error. And so with this, it actually suggests that there is a presence of infection at this time. And again, go back into the scenario. The patient is dealing with a peritoneal dialysis. And remember about the very common complication, which is peritonitis. As I have discussed yesterday, this is a complication that can easily occur when there is unsafe practice in the insertion of the peritoneal catheter, poor hand hygiene, unsterile technique. So peritonitis can really set in easily to this patient. It will compromise the peritoneal membrane and also decrease its ability to filter the solute. So it will become an ineffective dialysis. All right. So we are gonna possibly put this in the parking lot as one of the as the correct answer. A is already wrong. Because hematocrit really is not gonna prevent us from proceeding with the PD. Now let's take a look at letter C. Potassium level of 3.5. What do you think about potassium 3.5? Is it normal? Yeah, it is normal. The range that we have discussed is 3.5 to 5.0 milliequivalents per liter. And so this is something that we're not gonna worry about. We're gonna X that out. It's unnecessary. It's just a distractor. It doesn't cause any problem to continuing PD. Now let's take a look at letter D. Blood glucose of 210 milligrams per deciliter. This is a high blood sugar reading, right? It is elevated. It indicates hyperglycemia. We know that. But this is not uncommon in patients with CKD, particularly for those diabetic CKD patients. And so this is something that we need to manage accordingly, but it does not signal an acute or specific problem with the peritoneal dialysis procedure. Like I have said yesterday about the PD, that one of the possible complications would be hyperglycemia, right? And I said something about managing it with a dose of insulin, that this is something that can be easily managed, but will not contraindicate in proceeding with the next session of PD. All right, so we are left with letter B. That is our correct option. And so for now, the testing strategies at this point is again to understand the context. So the question is about identifying the significant problem during the PD. So we need to recognize that the complication associated with the PD can include the infection, especially peritonitis. So it really pays to, for if you are really listening to the discussion, it would really help you quite a lot. Now, again, the next testing strategy here is to eliminate those clearly incorrect options. Incorrect for letter A, also letter C is incorrect, and letter D is also incorrect. Those are obvious reasons that will not hold us into doing the next dialysis session. Now, another is that we're going to have to focus on the critical findings. So which is critical here? Is 34% a critical finding? Heck no. What about the potassium? It's not. Is the blood glucose 210 milligrams per deciliter critical for this patient? No. So we are left with, again, letter B. 22,000 is way, way, way above the upper limit, which is the 10,000. And so this is a serious complication of PD, and peritonitis, again, is a major concern that we need to deal, because this can cause a major sepsis into our patient. It will readily cause havoc into our patient systems. Now, we are going to also apply the knowledge that you had gained regarding the complications of the dialysis. We need to understand or recall that peritonitis is a very common and serious complication, and again, it is associated with an increase in the white blood cell count. And we have to recognize that the question is testing knowledge of recognizing the signs of infection and also the complications specific to the PD. So this is where we're going to end our discussion today. I will see you again tomorrow for the next topic. We'll be talking about glomerulonephritis in adults. And so I hope to see you again tomorrow. And again, please don't forget to like this video and share with your friends so they will be able to participate for the next session tomorrow or the succeeding days. So thank you so much for your time. You have a great day. You have a happy week.